high atop Caesar Rodney Square in beautiful downtown Wilmington, Delaware.
We are the Podcast Pediatricians. I'm Matt Gotthold.
And I'm Rob Walter. Check us out on iTunes, Spotify, Google Play, something called Podbay, podcastpediatricians.com, and Facebook. So today we finish a truly epic, if we do say so again ourselves, and of course we do say so,
all day long,
discussion of pediatric headaches, much based on the wisdom of Dr. Mark DiCipella of Children's National, plus some Tara Pizzuto from right here at Nemours Children's in, again, beautiful North Wilmington, Delaware.
And now our disclaimer. We're sharing our own personal opinions on pediatric care. Always talk to your own pediatric caregiver about your child. Pediatric caregivers should always consult expert guidelines and consider their own community standards of care.
And remember, anything we get wrong is on us, not Dr. DiCipella or nurse practitioner Pizzuto.
All right, man. So we had some big doings lately, right?
Been a long time since we did this.
Indeed. Yeah, we're not very consistent, I will say.
And
that.
the big event, the wedding.
Yeah, my daughter Victoria got married, and I must say it was really one of the most phenomenal days, probably in the existence of the planet. But first of all, in my life, it was everything I hoped it would be, and I hope it was everything.
It was great. It was great. You know, the moments, the aisle, and it was a beautiful outdoor ceremony. Your toast about how you talked about you were the first person who ever saw her, and she's yours. That was great. But then on the weird stuff too, like the story about that I heard about how you kill baby bunnies.
I didn't mean to share that, actually. That was a long time ago, man, and it was inadvertent. So that's more of like a manslaughter than a murder. I think.
Lawnmower manslaughter.
It was, yeah.
And then your partner going on and on about how he is obsessed with the Flow Rider on cruise ships.
My fantastic partner, also one of our best friends, and in our book club, I think takes cruises only to ride the Flow Rider thing on
I
there.
know.
I mean, he's there. It's like him and 3 12-year-olds all day long on the thing. He's you're up, old man. Cool. Yeah. But he's obsessed. He is. So for those who don't know, it's kind of like a surfing machine, right?
For 12-year-olds.
And apparently for 48-year-olds.
Who get up at 6 in the morning to be on first online the entire day.
I love my man, Jason.
Oh, man. And my daughter's wedding's upcoming, so I was taking lots of notes. I actually went to this retreat and Mohunk in the Hudson Valley, but I just mentioned that because I actually have this skill at tomahawk throwing.
Ooh.
That I think that at your next big barbecue, we need to get some barbecues. Yes, yeah. I'm trying to convince my daughter Abby to maybe have a little tomahawk throwing at the wedding she's having, but no. I don't think that's gonna.
So that's gonna top our cornhole, huh?
It's not gonna fit her vibe, and just to touch on, a lot has happened in the world since our last podcast, and the biggest thing, which is just like every day we talk to each other, we're just so depressed, is the gun issue.
Yeah.
And Buffalo, Uvalde, Philly. I don't know what it's going to take to limit these weapons of destruction. Gun violence is now the leading cause of death for United States children, up 30% in 2020, and exceeds car crashes. So we always said, the number one way you die as a kid is car crashes. Now it's guns.
And I don't think either one of us are railing against hunters or anything like that.
No.
But for God's sakes, there have to be some reasonable criteria to be able to have someone own a gun, and it's insane.
They just passed the law that's going to limit. It's not enough, but it's at least something, at least a ray of hope. And there was a bit of a controversy, and I can see it. Like, should they show pictures of kids killed by an AR-15? Because basically they've been decapitated, and obviously with only the parents' consent. But I think that maybe they should if their parents want to. I mean, let people kind of know what these are doing. These are not just hunting rifles. I mean, they're military grade weapons. That why do people need them?
Again, only in the United States. Right? Why is that?
Right.
We laud ourselves as being civilized and democratized and everything, and yet the most vulnerable people in our country are in peril.
Right. And we know that pediatricians, we know that young people's brain are not matured, especially boys. So an 18 to 20-year-old boy, why let them have one of those weapons of mass destruction?
Unbelievable.
And of course, I know Matt's big highlight of the spring is the Oscars. He's all about the Oscars. So I have
Oscar Grouch.
I have a joke for you, Matt. Ready?
All right.
What did Chris Rock find on his face after the Oscars? Fresh Prince.
Okay. That's corny enough to use.
Not good taste. I don't think Chris Rock knew about the alopecia at all. And, Will Smith has won 11 Nickelodeon Kids' Choice Awards. I mean, it's so horrible that it was him. And he's so Philly, it hurts. But, yeah, it hurts that he's so Philly now. So
golly.
I just don't know what to say about it. I think they should have Chris Rock host next year. He kind of ruined this beautiful kind of Philly moment with Questlove.
Yeah.
Did you see that movie?
I have not.
Summer of Soul. You got to watch
list.
it.
No, as soon as that came out, because I'm a fan. Just the fact that he's such a talented musician, and he's actually socially a motivator and really a historian. A historian of really important music.
And it can reset what you think of that, because I grew up like Woodstock.
Right.
But at the same time, there was this Summer of Love in I think it was in Harlem that was amazing.
Yeah.
That I never knew about. So everybody out there should watch it.
Yeah, I look forward to seeing it. All right, let's jump into the other big topic right now that's in the news. So infant COVID vaccines.
Yay! Yay!
So finally, about 6 months later than we anticipated, the COVID-19 vaccine for 6 month to 5-year-olds has been approved and is ready to go now. In fact, it's starting to be administered some places already, and I think that Rob's practice and mine should be starting
this
within
week.
The next week or two.
This
right?
week,
yeah.
Yep.
We do recommend it, but we also understand that it can be a tough sell since we keep saying that the younger kids have a bit of an innate immunity and don't get as sick. But, we also have to big picture this. There have been almost 500 deaths in children during this pandemic from COVID-19. COVID-19 is more deadly to younger kids than many of the other vaccine-preventable diseases, like, for instance, chickenpox, which, again, we do encourage that vaccine as well.
Right.
And the youngest of kids with COVID-19 do have higher rates of ER visits and definitely of hospitalizations than the older kids, especially when they have underlying conditions. And then, of course, there's the multisystem inflammatory syndrome, and that's serious business.
We have a child in Nemours, the Children's Hospital, with that right now. It really is. There's also implications for travel with the rest of the family, since often it's these youngest kids who are the only ones who are not immunized. And we also want kids healthy to start the new year. They have to be in school. They have to be there in person. There's 2 choices, Pfizer and Moderna, and suffice to say that either one would be great. Pfizer's 1/10 the usual dose of the older adults, and it's 3 shots, with the first 2 3 weeks apart and the third one 8 weeks later, so over a minimum of 11 weeks. And the Pfizer has a little bit less side effects like fever, but both the Pfizer and Moderna can cause fever, chills, headaches, or soreness, but these are pretty mild and usually very short-lived. The Moderna right now is a 2 vaccine regimen, 4 weeks apart. And we do hope that as many of our youngest patients as possible get these vaccines, and look forward to the fall when hopefully there'll be better vaccines, more tweaked for the newer strains like Omicron.
Yeah, and I was just talking to Rob before we started this podcast, and our next episode is going to specifically be about the COVID vaccines, specifically for younger kids. And I'm actually going to write this one. Rob writes all these other ones. I just tweet. I'm like the color commentator. Rob's the brains here. I'm just like the guy in the street going like, yeah, what he said, right? So, but we are going to drop that hopefully within the next 3 weeks.
All of you out there who know Matt are thinking, yeah, we'll see.
Summer of 2023.
It may have to be after Hot Topics at Disney World, because we got that coming up.
All right, so moving right along. Now let's touch on some of the pearls that we recently dropped at our Rehoboth Beach meeting, where the podcast pediatricians were the headline performers for our 40 minutes.
We brought down the house.
We
sang COVID days again. COVID days. People
much
were
to my disgust,
laughing and cheering. Someone threw some underwear at Matt. Turned out it was Matt's underwear. He left it in the hotel room, but still, it was quite a heady, exciting time.
Man. Let's talk about some new antibiotic guidelines for ear infections. So it's recommended still that 10 days of antibiotics be given for severe or bilateral or recurrent ear infections, or if a child is under 2. But otherwise, if an ear infection is uncomplicated and the child's between 2 years and 5 years old, then just 7 days of antibiotics is the current recommendation. And if a child's 5 or older, then just 5 days seems to do the job.
That's a big change. We did point out that studies show that still over 90% of pediatric caregivers give 10 days for everyone. And 40% of caregivers often don't use amoxicillin first line in uncomplicated cases, which we should. So, Matt, you using the shorter courses?
I have been with the older kids. Yeah, and I have been doing that for a while. I mean, essentially, like, hey, listen, when it feels better, as long as I'll usually say at least 5 days have gone by, you can stop. Because again, we've talked about this before, but those antibiotic guidelines of 10 years really, from my understanding, emanated from strep studies from the 1950s. So it's really arbitrary. I mean, every ear infection is different. Every child is different. Every child's immunology is different. And honest to God, 80% of ear infections are going to go away on their own.
Right.
So it has always been really, it seems like ear infections in pediatrics are joined at the hip. And this is for sure, because it's a common thing that we come across, but it doesn't have to be as complicated as we make it.
Right, and the other big paper that was more just this spring and winter was community-acquired pneumonia treatment only needs 5 days. Not only was it as good as 10 days, it was better than 10 days. So really, I'm trying to shorten that up considerably. Usually amoxicillin, there may be times to give azithromycin for that. And just lastly, a couple months ago, this article from Mike Picicero, the otitis media guru, antibiotic guru, that use of antibiotics reduces the response to immunizations. So we're learning so much about immunizations, the immune system, because of COVID and the pandemic and people studying this. So another reason to have good antibiotic stewardship. So I also mentioned at the meeting very quickly about TikTok ticks. You know what TikTok ticks are?
I barely know what TikTok is, man.
So these are sudden, severe, physically large movements with vocalization in girls mostly, triggered by these same girls watching Tourette syndrome videos over and over on TikTok. And it really was real. They're presenting with these kind of tics, and only, with their social media, it's just only the start of...
only in our culture.
It's crazy. So that's TikTok tics if you see that in your offices.
Let's move on from that as quickly as we can. So more from our talk. In JAMA Pediatrics in November of 2021, there was a great study showing that limiting screen time for the first 48 hours after a child has sustained a concussion decreases the concussion symptoms by an average of 4 days. This is huge. Yeah. We've always advocated that kids limit their screen time, that their visual stimulation be limited after they've had a concussion. But this really speaks to at least some definition of, okay, if you do it for this long, it's going to save you this much aggravation.
Very simple.
Which was awesome.
Right away.
Super simple.
4 days.
Mm-hmm. Yep.
4 days saved.
Also love the paper from the British Medical Journal that we covered, which looked at emergency surgery mortality rates in adults, and these were significantly higher if the date of the surgery was the surgeon's birthday. I guess they were a little distracted, right? Although for some of the surgeons we know, it was probably the day after their birthday that was more of an issue.
Right, but it's understandable, right? First of all, if you're on call on your birthday, you're not going to be in a good headspace to begin with. Or maybe you went out for dinner thinking, hey, I probably won't get called.
Right.
So, I mean, it was kind of funny that they even looked at this.
Yes.
But it gets to the point that, our social lives, our personal lives do bleed into our professional lives, and especially for surgery. I mean, I think I know that for the rest of my life, when me or my loved ones having surgery, I'm probably going to say, so when's your birthday?
That's right.
And they'll say, I'll just mention the articles, so it won't be so weird, but I definitely will. All right, so now, of course, Matty Ice, we need to touch base about monkeypox.
Monkeypox.
We're not going to do a deep dive on monkeypox, but how can we not talk about something called monkeypox?
It is a cool and intriguing name.
I don't know about you, but as a pediatrician, when I hear about new infections coming on, the first thing I want to know is this affecting kids? And actually, this is not affecting kids yet. So it certainly made me a little bit less vigilant about finding out about it in a deep dive right away. It's like, okay, it's not affecting kids. And I didn't want to expand too many of my brain cells on it. It was first described in the 1950s, and yes, in sick monkeys in sub-Saharan Africa. It does spread to humans. Actually, they've known for a long time the reservoir probably is in rodents, not actually in monkeys. So monkeypox name is kind of a misnomer, and many people are trying to change it. I'm not sure if squirrelpox is going to be as catchy, because I guess they think the main thing is some kind of African squirrels. But squirrelpox, I think monkeypox sounds better.
The monkeypox virus is a virus similar to the smallpox virus. The rash consists of pustules that are all relatively the same size at the same stages of development just the same as with smallpox. It does like to show up on the palms and the soles, which reminds us as pediatricians of something that we see very commonly, which is Coxsackie virus or hand, foot, and mouth
Which we're
disease.
starting to
Seeing again.
a lot
Absolutely.
again.
Yeah, it's summertime. That's what we see, right?
It also reminded me of like in med school when they talk about what's the difference between smallpox and chickenpox. Smallpox are always at the same stage, and chickenpox are all different
Evolve
stages.
at different stages, yeah.
Right.
So the hallmarks of monkeypox are rash, fevers, chills, achiness, and some enlarged lymph nodes. In the last several months, there have been about 2,000 cases of monkeypox outside of Africa. It's seen more often in men who have sex with men, and it seems to be very much related to close contact, but it's not necessarily sexually transmitted. The good news is that while the endemic of monkeypox in Africa can have mortalities of 5 to 10%, which is scary high, there have been no deaths with this non-endemic form so far.
I know that is great. Some of it may be because of malnutrition in sub-Saharan Africa and lack of some hospital resources, but still, it seems to be a different animal. And the nice thing about it, you can say the nice thing, but the nice thing about monkeypox being like smallpox is that the smallpox vaccine, which we have stockpiled in great numbers in case of a bioterrorism attack of smallpox, does also protect against monkeypox. So there's been some strategies of ring vaccinations when they have a case of this non-endemic monkeypox, just vaccinating every one of their contacts using this smallpox vaccine. Also, antiviral medications stockpiled for bioterrorism reasons also seem to work against monkeypox. So hopefully monkeypox will not be a growing problem. We all have pandemic fatigue, but it's nice to know that our worldwide public health systems continue to look for and try to mitigate infectious threats. And as we hopefully have learned from COVID-19, these threats are out there. We need to be vigilant and believe in science and fund efforts to identify and protect and prevent the next one. Okay, Maddie, finally, we're going to delve into migraine treatments. And I'm going to try a little experiment in wireless electromodulation with you. So during this episode, I've already put it on Matt's arm. I'm going to dial up a little electric stimulator that we'll talk about later that can be used for migraines, starting low 10 to 20% and going up to close to 100%. Now, I did this on myself. I easily got to 90%, but I am from the mean streets of Syosset, so I know that probably I'll be able to take more than you. So you're from a softer upbringing in the swamps of Jersey, so
mean streets in Syosset seems like an oxymoron.
Have you been to Syosset?
I've not.
Okay, well then
I'm not sure they'd let me through the gated community.
Okay, so hold on. Okay, Matt, I think it's set up, and here it goes.
Ooh, that's very tingly.
Do you feel anything?
Yes.
Oh, you feel the tingle?
Oh, I do.
Okay, so
although I don't have a migraine, does this mean it's going to give me one?
I don't know, but during this episode, I'm going to continue to crank it up.
I will say it's a little distracting. Yeah. Mm-hmm.
That Matt needs to be more distracted than usual.
Are these petechiae supposed to be here?
Don't worry about the blood. The blood is supposed to be there. Don't worry about it.
Yeah. We'll see. All right. So, yeah, that's weird.
You're only on 14%, Matt. I get to the
Crank
90s.
me up, baby. I can take it. We start with another little bonus from our friend and colleague, the indubitable Dr. Mark DiSabella, director of the headache program at Children's National in D.C. He gave a talk on tips and tricks of the trade in pediatric neurology, and we'll focus on his history and physical exam tips. So in neurology, as in much of medicine, but especially in neurology, history is where the diagnosis is almost always made. As he said, if you don't have a good idea of what's happening by the time you do the exam, then you're already in big trouble. According to Dr. DiSabella, the physical examination increases the diagnostic yield in neurology, but only leads to a diagnosis in about 1% of neurology patients. So, here are some neurology history pearls.
So, for pediatric mental status, just ask kids about things they know about. And don't have to get really fancy, just things they know about. So, for me, that's why I like to try to stay up to date on the newest video games, cartoons, music, sports, because that's a conversation starter. It's not because I'm weird. It's because it helps. So, a couple things here. So, Matt, let me ask you some quizzes here. Usual things you should know. Do you know what the Squid Game is? No. A lot of murder in that. Do you know who SpongeBob's best friend is?
I do. It's that starfish guy.
What's his name?
It's not Squidward. Patrick.
Good. All right. Ding, 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 ding. Do you know who the founding Mandalorian wannabe who escaped from inside a Sarlacc and now stars in his own mini series on Disney Plus?
Baby Yoda.
That's a good guess. No, Boba Fett.
Oh.
Okay. And then what is the name of Taylor Swift's new album? It's the color of her scarf.
This one I think I know just because I follow music a little bit.
No.
Is it red?
It is.
There you go.
But here's the extra credit. Where did she leave the scarf?
Some dude's house.
Well, I saw the music video. So she left it at her ex-boyfriend's sister's house.
Oh. Because that really changed the course of my life. Yikes. I'm not embarrassed at all, by the way.
Did I know that?
Things.
Yeah. I should
So
be
Mark
embarrassed.
gave some pearls for examining the optic nerve with an ophthalmoscope. He made the point that only half of practitioners feel comfortable doing the fundoscopic exam, and many fake it. How about you, Rob?
It is, it is really hard. I actually sometimes try to do it on well exams because if we're not too busy, because you got to practice at it. And some kids' pupils are just tiny, right?
are.
Like you're trying to look and it's going through this tiny hole and then they're moving around.
Mm-hmm.
So some people say I can see everything. I mean, sometimes you see a certain kid, you're like, wow, I can see it really easily, but it is really hard. I'd love to dilate the eyes routinely like our ophthalmology colleagues do. For myself, I'm struggling because I think I need glasses soon. I'm going back. Do you have glasses?
I do.
You do, right?
Yeah.
So
I occasionally wear
because I'm going to lose them. So
I do.
And I also developed a floater, which is this where your jelly-like vitreous starts clumping in your eye. There's no cure for it. It's this black thing. Do you ever have that?
Rarely.
Okay, so I went to see my ophthalmologist, Jamie. I'm like, what caused this, Jamie? And she just looked at me and she's like, oldness.
If that's not a word, it should be.
It's my diagnosis, oldness.
I'm surprised you want to dilate anybody's eyes because kids are usually scared to death when they go to see you, and then people should be nicely dilated already. I remember when I was a medical student, and you probably remember this, but when you're studying under somebody and you're not quite clear on what their objectives are for you, and you're afraid that they're going to ask you, what did you see, Rob? Yeah. If I had somebody I wasn't afraid of when I did the optho exam, I would just get up there and start flicking the little clicker, right? Because that makes it seem like you're doing something, right? So you go click, click,
Right,
click, right? Yeah.
La 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 la.
Yeah, I teach the medical students that I teach that if you want to get by on somebody, you just do that, and they think it did something, right? So more ophthalmoscope tips include leaving the patient's glasses on or their contacts in and having something on the wall for them to focus on. For the left eye, you want to have them look about 10 degrees to their right, and for the right eye, have them look about 10 degrees to their left. Tell them to focus on that area, even if your big old noggin gets in the way. And I actually use another thing to help me focus the ophthalmoscope, although I'm usually the only one using it, so I don't know why I keep doing this. But I'll focus on the creases in my hand at about the distance that I'm going to be from the child's retina, and that already gives me a starting point.
Oh.
So that really has helped me. Again, Rob just pretends that he's looking at it anyway. And you really need to get pretty close to their eyes and face, almost cheek to cheek. So optimally, you use your left eye to look in their left eye and your right eye to look in their right eye. And again, this is quite an orchestration of varying skill sets, fine motor and gross motor. So for a lot of folks, it's just easier to stick it in your, at your one eye and then take a peek.
Right, you got to get really close.
You do.
Matt, we're going up to 30%.
Ooh.
How do you feeling?
My left hand's turning purple, but I can take it because...
You're tough.
I can take
tough.
it. Yeah, right.
Mark also made the point, a lot of laughter in the audience said, is forget about looking at the vessels in the eye. We're taught about venous pulsation of the eye, looking at the optic cup, but most of us are just thrilled to see the disc, see whether it's if it's sharp or not, and then just get out of there. We're not looking for anything else.
True.
He also made the point that color vision is actually the first thing that's lost when there's increased intracranial pressure, and that you can use the free colorblind app on your phone. And I have that app, and I've used it on teens and such, but I can't say I've thought about using it specifically if we were worried about increased intracranial pressure.
Yeah, no, that was a great point. Yeah, and the other great point they made that actually was a surprise to me, he also reminded us that the visual acuity, or how well you actually see, is usually not affected by brain issues, like increased intracranial pressure, but by eyeball problems. So most brain tumors don't cause blurry vision, which to me was really quite an epiphany.
Right.
Yeah.
His last pearls were about deep tendon reflexes, and I found that was the most fun. of his talk. And he actually used me as a model, and Matt was cackling in the audience in Disney World last year about it. And he did the brachioradialis reflex. You hold one arm up by the thumb and tap on the distal forearm radius, and you look just for a little bit of a wrist twitch. And the other main reflex that we all do is patellar reflex at the knee.
Yeah, we've said before that we rarely ever make any major diagnostic insights using the patellar deep tendon reflex on well visits, or even on sick visits for that matter. But the kids expect it, and it's always fun. Mark made the point about not missing absent deep tendon reflexes in babies. So that when there's no reflex, and it feels like you're tapping a bag of flour, which I thought was a great description, in a baby who is already floppy or hypotonic, you have to think of spinal muscular atrophy. There are now new gene therapy treatments for this condition that can be unbelievably life-altering. So it behooves us to pick up this diagnosis on children as soon as we possibly can.
Absolutely. That's the difference. Right now, you can do something about it, and you want to do it fast. And again, his best pearl about reflexes was, and it's been amazing, is his advice about getting rid of our old triangular Taylor hammers, which cost about $10, and buying some Tromner hammers, which costs less than $15 on Amazon, includes a little brush in the handle for examining light touch, and it's weighted perfectly to make it easier to elicit reflexes on exam. So I bought some. I've got one in my hand here, a new one. Have you tried these, Matt?
Oh, you're going to whack me
it.
with that while you're electrocuting my arm?
It's so much fun, and you get such better reflexes.
Yeah.
So, throw out your old triangular hammers, because they're awful.
No, and upon Rob's advice and upon editing this issue, I actually jumped right on Amazon and bought myself a couple of these. So we'll see. I'll give you a status report, Rob.
And then my favorite reflex thing to do in the office, I talked about how to do their knee exam, but you want to get in front of the kid. I'm usually in my wheelie stool, and then put your leg in front of their leg, and then elicit the reflex, and then they kick you. And then say, "Stop kicking me," and then you hit them again, and they kick you again. You go, "Stop kicking me." It sounds stupid, but they just start laughing, and the siblings start laughing, and I'm going like, "Ow, he keeps kicking me." Anyway, and when I come back the next visit, like, "Let's do the thing again when I kick you." So I definitely, and then I usually go on my dictaphone at the end and say, "Johnny kept kicking me the whole exam." So just anybody out there want to have a little levity in your exam, I encourage you to do this with the reflexes.
Go see Rob and kick him. Yeah. Okay, after the break, we finish headaches with our discussion of treatments. Okay, let's jump into headache treatment. We'll concentrate mostly on migraine treatment. We'll begin with headache prevention, lifestyle modifications. These are huge, and again, like with most of health, these little things are oftentimes overlooked, but they are imperative to addressing things. So addressing headaches in this way really applies to both migraines and distress headaches in both kids and in adults. We like our patients to keep a headache diary so we can review it with them to see if any specific triggers can be identified. Of course, stress itself is a trigger, especially during the pandemic, with anxiety and depression going through the roof. Certainly, we've seen an increase in headaches, as we mentioned last episode.
Yes, so much stress out there. Matt, I'm dialing you up to 40%. Is that stressing you? You feeling it? You feel it more?
I have an urge to urinate, but I'll hold it.
If you have a heart attack, it's going to piss me off, okay? Because that'll be really embarrassing.
We'll find a new partner.
We won't be able to publish this podcast, so that would be bad. So first-line treatments for headaches starts with hydration, hydration, hydration. I tell my patients they should drink at least their weight in pounds often per day, up to about 70 ounces. And we know most teenagers might not get that 70 ounces in, but the point is they should be drinking a lot, carrying around a water bottle. If they're not peeing a lot, they're not drinking enough. They should also avoid caffeinated drinks, especially avoid artificial sweeteners. All of these suggestions are put into their written action plan. Now, the second lifestyle change, of course, is good sleep hygiene. And anyone who listens to us know over and over again we talked about sleep. And again, asking what time to get up on school days and what time to get up on the weekends and holidays. There shouldn't be more than a 60 to 90 minute difference between that. And again, they can't bank their sleep in the weekend. They just shift it later. And they're staying up late on Friday and Saturday nights. So you want them to get at least 8 hours sleep. And if they have migraines and really have difficulty falling asleep, I'm quicker to use things like melatonin because, they need to get a good night's sleep. Although we do know that long-term melatonin has problems also, so we have to be careful about it.
Yeah. Of course, less screen time can help, but a key factor in preventing migraine headaches that often is overlooked is engaging in some type of a vigorous exercise of at least 5 days a week for at least 30 minutes each time. The vigorous part is really important. In fact, HIIT, high-intensity interval training, with bursts of anaerobic activity really works best.
Yeah, and Mark mentioned that. As soon as he mentioned it, I'm like, okay, you must have a Peloton. And on the stage, I said, you've got a Peloton. And he's go, yes, I do. And I asked him what instructor he likes best. He would not tell me who he liked, but I'll say I liked Emma Lovewell, Allie Love, and, of course, Cody. So, Matt, you have a Peloton, and who's your favorite?
What do you think? Eating 3 healthy, well-balanced meals per day has also been shown to be important, as well as avoiding fasting for more than 4 to 5 hours. One certainly wants to avoid sugary drinks, corn syrup, chemical preservatives, and high-salt foods. Eating foods with artificial coloring and artificial flavoring is particularly bad for headaches.
And we specifically ask about certain foods that have traditionally been linked to headaches, like peanut butter and chocolate. Although it's not that common that those are actually the culprits. The one I find over the years that has been most associated with migraines in my older kids, college-age kids, is ramen noodles. There's such a high salt load. It's very artificial, very processed. And so I do specifically tell them to avoid ramen noodles if they see any connection to their migraines. Bumping up to 46. How you doing there, Matt?
The Fitbit down that arm is starting to smoke, and it says my heart rate's 180.
One of the audience members during the talk asked about DAITH, D-A-I-T-H, piercing to prevent migraines. And I had never heard of it, but actually, and I thought it was kind of a weird question, but Dr. DiSapella immediately said, yes, he's heard about it. And basically, it's piercing the cartilage above your external ear opening or even piercing the tragus in order to prevent migraines. And the theory is that piercing here almost acts like constant acupuncture. And certainly we know that acupuncture has been used effectively to prevent migraines. And I did a little mini research on this topic later. There does not seem to be great evidence for its effectiveness. And there does seem to be big placebo effect, and as we know, placebo effects can be good.
Super.
But as you said before, we know that cartilage piercing has real risks of pain, keloid disfigurement, and possible serious infections causing ear deformities. I know Matt's practice does do cartilage piercing for all their patients, and I will definitely defer to his expertise here.
Actually, we found tattooing and septal piercing is much more lucrative. Yeah. But that's for another day.
Yep.
Let's touch on the use of supplements that could be considered in an attempt to prevent migraines. The classic supplement for this has been riboflavin, which is also known as vitamin B2, 100 milligrams twice a day. There have been good studies showing that this can be effective. An alternative to riboflavin is coenzyme Q10, also 100 milligrams twice a day. Again, this has demonstrated effectiveness, but it may be better for post-concussive headaches than for migraines.
And, recently, a lot of times I learn things from looking at the specialist reports that we get and say, what are they doing now? So I've had a few, both children's hospitals near us, CHOP and Nemours, who had recommended the over-the-counter Migrelief, which is riboflavin, magnesium, and feverfew. So that may also be worth a look.
Yeah, feverfew is actually fascinating. It's apparently good for pretty much everything that ills mankind. So check it out, feverfew. There's actually a great article on PubMed about this that was just a recent review. It's really fascinating.
Doesn't that make you skeptical when someone says it's good for everything known
right?
to mankind?
Well, yeah, let me see here. Psoriasis, allergies, asthma, tinnitus. Yeah, I could go on and on. There are, of course, prescription meds that are used to prevent migraines, and these include amitriptyline, which is also known as Elavil, for which one may want to check an EKG first, and topiramate or Topamax. These often need to be taken for at least 4 weeks in order to see a positive effect, so you have to tell the folks that you're treating this. Then there are the old standbys, cipraheptadine, also known as Periactin, and propranolol. And then there's a newbie, which is Botox injections. So there have been quite a few studies on Botox, and we have each had patients treated with this, usually at headache centers like Jefferson or Penn. Dr. DiSabello isn't really a huge fan. Some studies show that Botox improved the number of headache days by only a decrease of 2 per month. And the question is whether that degree of improvement is worth getting 30 or so injections over 12 weeks. But, again, for some people that might be a good thing.
It might
you
be.
bet.
All right, Matt, we're dialing it up.
60%.
You feel it? You feel it
now I'm not kidding. Like my muscle is spasming.
You want me to stop?
Not yet.
Okay.
My muscle is spasming, and every once in a while, both my biceps and my triceps are twitching.
Oh, you should see it. We'll try to. I'll videotape it. It's kind of no, I can't see it. I think most of us general pediatricians leave these considerations for some of these type of medications to neurologists, and I have seen quite a few papers the last few years showing that these medications to prevent migraines don't work that well. But again, for individual patients, they may have a place in some situations. All right, so Maddie, you suddenly get a migraine or a headache. So now what do? What treatment do you think about now?
Well, Roberino, the one non-medicinal thing that you can do right away is to have the patient drink 10 to 12 ounces of a sports drink like Gatorade. Again, try to stay away from those artificial colorings, so try to make it a clear Gatorade without the artificial colors. We know that high sucrose sugary drinks do act as an analgesic and reduce pain. And so, for instance, sucrose is oftentimes given to babies before a circumcision or a heel stick. Your brain loves sugar, right? And so this hopefully should make it a little happier than it is in the midst of a migraine.
Right.
After the sports drink, then you want to treat the pain. We usually start with ibuprofen at a dose of about 10 milligrams per kilo, generally to a max of 400 milligrams. That's 2 of the adult tablets for the older kids. We can go higher, but there's no great evidence that 600 milligrams works any better. Another decent over-the-counter option is naproxen, which is also known as Aleve in its formal name, which is longer acting than ibuprofen. Most patients find that acetaminophen or Tylenol isn't terribly helpful for their migraines. A side point here is that medication overuse needs to be avoided.
This
is super common and oftentimes something that I personally forget about. So, but medication overuse headaches can be caused by using over-the-counter pain medicines or even the triptans, which we'll talk about in a minute, for more than 2 to 3 days a week. Tara Pizzuto, our local NP who specializes in headaches, really stresses this point. Medication overuse headaches are very common and debilitating and can lead to chronic migraines and even to status migrainosus, an especially severe and long-lasting form of a migraine headache, which is also known as an intractable migraine.
And of course, many practitioners and patients use combinations of pain medications with other ingredients, such as caffeine. Classic example, combination of acetaminophen, Tylenol, caffeine, and aspirin, like in Excedrin migraine. And caffeine has always been so interesting to me because while it can be a cause of migraines from overuse, it also can be used as a treatment. And, I don't usually recommend these types of medications, but some patients like them. Again, medication overuse is a big risk here, but many come in saying, my mom has migraines and this always works for her, and they take these and I use them and it works. If it works, it works. Just we need to warn them about not overdoing it. So today, boys and girls, we're not going to get into treatments of migraines in the ER, but obviously there are times it's appropriate and necessary. And ER treatment often starts with IV fluids, administration of anti-vomiting medication like metoclopramide, also known as Reglan, ergotamines, and steroids are sometimes used. But a lot of the newer guidelines, I know at our children's hospital, really stresses trying to avoid migraines. And Tara Pizzuto made the point that sometimes people say their migraines are from sinus headaches. And some ENTs will just give Medrol dose packs and say, okay, and treat for antibiotics and say, yeah, it was for your sinus. But actually, they're just treating a migraine with steroids, and it's not the best way to treat it.
No. And this brings us to the main medications that most people think of to stop a migraine in its tracks. And these are the serotonin receptor agonists. They're also known as triptans. So triptans are a family of tryptamine-based drugs that are used as abortive medication in the treatment of migraines. These meds were first introduced in the 1990s. Although they can be effective in treating individual headaches, they don't provide preventative treatment and are not considered a cure for migraines. The key for using triptans to stop a migraine is to take it as soon as possible, and this can't be overemphasized, early in the course of the migraine, preferably during an aura if it's experienced. When effective, the patient can actually then, in a short period of time, go on with their regular day. There are at least 7 different triptan medications. As pediatricians, we want to have a few that we're comfortable with. This is similar with other drug classes as well. There are a few that we kind of keep in our corral. Here are the ones that Dr. DiSabella mentioned and the ones that I think both of us use the most. The first, and one of the most popular in pediatrics, is sumatriptan, or Imitrex. The key here is that only the nasal form is really effective. So it comes as an oral, but the nasal form is the one that's effective. Starting at age 5 and up, the dose is 1 spray, or 5 milligrams, into each nostril once. If the headache persists, this can be repeated again in 2 hours, and generally then that is the limit of the dosing. And that's usually the first line. Robbo, what do you think?
Well, Matt, we're going up to 70. How you doing?
The entire left side of my body is aching. Actually, 70 hurts a bit, dude.
Okay, you want to go down?
No. I'm good for now.
Okay. Okay. You know, again,
I'll be looking to have a prosthetic fit sometime within the next 3 weeks, apparently. But I didn't give up.
So where were we? Oh yeah. So yes. So nasal first line with the younger folks, yes, who can't swallow pills. The other nasal spray he mentioned was Zolmitriptan or Zomig, and has the same dosing, but it's only for age 12 and above. It also comes in oral disintegrating form for those who can't swallow a pill. Again, only for 12 and above. Now, the only pills that can be used in under 12 down to age 6 is rizatriptan or Maxalt. This starts at 5 milligrams from 6 to 12, goes up to 10 milligrams for over 13. He was really enthusiastic about Maxalt if a child can't swallow a pill if they're under 12. And I actually started using that more first line in those situations, and I've been impressed. I don't know if you've ever used Maxalt. But,
I do. In fact, that's my go-to. Usually.
Is it? Okay, now I learned that. So maybe it should be our go-to. Another triptan he mentioned was Axert or Amitriptan. Again, it's only available for those who are 12 and over, and the dose starts at 6.25. I've not used that. Have you?
That's my arm spasm.
Okay. We're going down. You want me to stop it or go down?
You know what? Let's cease this experiment.
Okay, we're ceasing the experiment.
Rob, you're a better tolerator of electromagnetism than I am.
Okay, wait a minute. Let's stop. Stop treatment. All right, did it stop?
Yes.
Did it stop? All right. And let's get full disclosure. I got up to 90% for about 30 seconds. I didn't do it this long.
Thanks, man.
Okay, you're welcome. How you doing?
No, actually, I mean, it was when you weren't thinking about it, it wasn't bothersome at all. But
Right.
but it did actually make your muscles twitch, and it was on a pain scale, it was probably like a 4 out of 10.
Right.
But it was like weird. It was almost like
Right.
having a BP cuff on too long.
Right. The power of distraction.
There you go.
There. So
Very important.
We'll get to that at the end here.
Yeah, so let's jump into another class of the meds. All right. So he also mentioned a class of medications called Tidans, which are 5-HT1F agonists used for migraine rescue. These have no effect on the heart's blood vessels, and this can be key, especially for older people, since the triptans are contraindicated in patients with suspected cardiovascular disease or uncontrolled hypertension, or with peripheral vascular disease. The main Tidan he mentioned is Yikes.
I knew that would get you.
Lasmiditan, or Ravo.
Nice.
It's not yet approved for kids, but it shows great promise.
Okay, I love to say this, Matt. Hold the presses. There's another new class of migraine treatments. They're called calcitonin gene-related peptide blockers, recently approved by the FDA for adults to prevent and treat migraines. And they show a lot of progress. You're already starting to see some of the ads on TV for these. Some of the migraine specialists, especially Tara Pizzuto, are unbelievably excited about these CRGP blockers. So their treatments include a group of monthly monoclonal antibody injections to prevent migraines. There's 4 of them currently on the market. All their generic names end with UMAB, and the trade names include Ajovy, Emgality, and Aimovig. They're injectables given once a month with a device just like an EpiPen, so it's pretty easy. There's a 4th one called Vyepti, which is actually an IV treatment. They're in phase 3 clinical trials for younger kids. They're reported to be safe even for those with cardiovascular issues. Pediatric studies are ongoing for teenagers, starting with those who suffer from greater than 8 intractable migraines per month. So these are the really, really, really severe migraine kids that I think those of us in pediatrics have handed over to neurologists. This med may be available for pediatric populations in about 3 years. Could be a huge game changer for those with horrible, intractable migraines.
Yeah, even more exciting in the short term are the Gepants medications, or as the French say, Gepants. These are first and second generation calcitonin gene-related peptide, or CGRP, receptor antagonists and have been developed for the acute treatment of migraines. Their generic names all end in the letter PANT, P-A-N-T. They block the CGRP docking stations. 2 of these have already been FDA approved. Nurtec, or Regimapant, and Ubrelvy. You put these in here just to screw me up.
I do. Ubrelvy.
All right. Ubrelvy, which is Ubrogepant. You may have seen these on TV. They can both abort migraines, and here's the interesting part, and prevent them.
Both. That's huge.
Booyah, as they say. The main side effects of GI are GI side effects, but they're not really terribly significant. A huge advantage of these medications is there's no concern for medication overuse syndrome with these meds. Another big issue.
Yep.
They can be used over and over again, and they won't increase frequency or worsen migraines like other medications can with overuse, including actually the triptans.
Right, not just Tylenol and ibuprofen. And again, the beautiful thing is they're both abortive and preventative for migraines. So for example, the Nurtec 75 milligrams has an onset in a few hours and lasts for 2 days. So a chronic migraine sufferer can use it every 2 days for a few weeks, both to stop an initial migraine and to prevent any more of them over that time span. It's unbelievable and beautiful thing for chronic migraine sufferers. I know after I heard her give this talk to us, like the next day I had a 22-year-old college student with horrible, intractable migraines. I hadn't seen her in like 2 years. She needed to go on to an adult person. So I did all my usual things and preventative and such in her sleep. But I was thinking kind of excitedly, well, if she doesn't get better, I'm going to start this because she's 22. And then she got better.
Bummer.
So I was very happy that our usual thing got better. But I was thinking like, it'd be nice to see if this worked. But much rather her not be on medication and just do lifestyle changes. And that's all she actually needed. But it is fun to hear about new classes of medications that can be game changing. And as much as we bash big pharma, and yes, we both say they can be horrible and the prices can be unconscionable. It's amazing when they develop a game-changing group of meds, and I'm really hoping that these will be that. But Maddie, so what if none of the above treatments help prevent migraines? Again, these headaches can be debilitating, especially to a child, an adolescent, or young adult. So first of all, let's say you have this person who's not getting better, had a good targeted history and physical. We mentioned MRIs are not routine for most migraine-like headaches, but if the headaches are not improved, especially after multiple months, then getting an MRI is certainly reasonable.
Yeah. So what are some of the other treatments for chronic migraines? Well, these include consideration for addressing concurrent anxiety or depression with stress-focused and pain-focused cognitive behavioral therapy. And this can really be helpful. Some of these approaches stress focus on the parent-child dynamic. This can involve encouraging parents to not have the child avoid activities due to fear of pain and headaches. So, oftentimes these parents become, kind of helicoptery and very protective and very fragile child-oriented. Therapists can help to identify and challenge negative thoughts like, they'll never make it through the school day, or the migraines will never go away. And oftentimes when we mention therapy to parents of children with some type of a pain syndrome, a functional syndrome, at least I'm sure Rob learned the same way, but to mention it as more or less, hey, listen, we know that this is really uncomfortable and painful, and it probably would help to have somebody to talk about that, about how to strategize of how you deal with that. So it's not specifically like, hey, you're anxious and this is why this is worse, right? It's more about, let's find you some strategies that you can use on a day-to-day basis. It's going to make your life a little bit more, a little bit less uncomfortable.
Right, and daily for the parents, if they're not basically bringing it up all the time and not making the child feel like I'm a migrainer, I'm a sufferer, as opposed to I'm someone who occasionally has migraines, but I'm not going to let it, ruin my life. Lastly, there is a home treatment program which uses magnet electricity, kind of like Young Frankenstein, called Single Pulse Transcranial Magnetic Stimulation, STMS. It's FDA approved for 12 and above, yet its mechanism of action and effects in migraines are yet to be elucidated. And it goes in the front of your head. It looks kind of strange. There's also remote electrical neuromodulation, or REN, for acute migraines, approved for 12 and above. This is the one that stimulates your upper arm peripheral nerves to induce pain modulation and decrease acute migraine pain. It's kind of like a TENS unit for musculoskeletal treatment. So you have this tingling on your upper arm when you get a migraine, and your body kind of concentrates on that and less migraines. It's kind of like the gate theory. Like if you had a bad migraine and I punched you in the face, you wouldn't really be noticing your migraine because you'd be noticing the pain on your face. And that's what we did with Matt. Little side effects. One study showed that for 12 to 17-year-olds, it had 71% head pain relief, and 35% were pain-free at 2 hours. And again, a dear friend at my suggestion tried this. It syncs to their phone like I just did here. And you can turn the intensity up as high as they can tolerate. For Matt, that was 70%. And usually do it for 45 minutes.
I guess I should consider myself like just a friend instead of a dear friend, right? Thank God.
All right. So so I don't know why we did that, but I just thought it would be fun.
I know why you did that.
Please don't take it. That wasn't an experiment. Matt didn't have a migraine, but I really enjoyed watching him sweat.
But he does now.
Okay, Maddie, we're done and done. Good night, Moon. See you all at Hot Topics Disney World on July 20th.
Be there or be square.
Podcast Pediatricians Productions. All rights reserved.